So welcome Dr. Mukesh Sharma.
Thank you, sir. Thank you so much.
Thank you for giving us time. I know all of you are, but half an hour for us. Dr. Mukesh Sharma, do we have Dr. Sirvi who can introduce? Or I'll do it myself. Anyway, he's a DM in neurology. He's a senior consultant neurology and neurointervention, Apollo Hospital, Ahmedabad. Organized a conference, Society of Neurovascular Intervention in 2018. He is a joint organizing secretary of Indian Stroke Conference Ahmedabad in 2019, and he has many papers and publications at different platforms. A speaker for all neuro topics. So welcome, Dr. Mukesh Sharma. I think over to you. Please share your slides and proceed.
My slides are there?
Yeah, they are visible now.
Okay, can you hear me?
Yes, very well.
Thank you, sir, for nice introduction. First of all, I would like to thank organizing committee for this invitation. We are going to discuss causes and management of stroke. You all know stroke is leading cause of disability, and around every 30 minutes, a stroke patient who could have been saved dies or develop permanent disability. You all know the stroke is two types. One is the hemorrhagic stroke and second is the ischemic stroke. Hemorrhagic around 12 to 15% and 85% around ischemic stroke. Today we are going to discuss management of ischemic stroke. Otherwise it will be difficult to cover in a short time. So we are going to discuss acute ischemic stroke management in two phases. First is the acute phase stroke management because it's similar in all kind of ischemic stroke, thrombolysis and thrombectomy. Then we are going to discuss secondary prevention, depend on the etiology behind the stroke, then conclusion. So starting with the stroke definition, a stroke occurs when the blood supply to the part of brain is interrupted, leading to lack of nutrition as well as oxygenation, and symptoms depend on the part of the brain. So the most important thing, the clinical diagnosis of stroke is very easy. Usually focal neurological deficit developed suddenly. So you are 99% sure the patient is having the stroke. It's maybe hemorrhage or it's maybe ischemic stroke. If it is not treated on time, this can lead to emotional, physical, even fatal consequences. So time is very, very important in these patients. So stroke should be treated as an emergency, like we are treating a MI, we are treating the roadside accident. So once the patient reaches to your emergency, there is a 4 phases treatment. First phase belongs to emergency physician. He should rapidly assess the patient and send for the investigation. He should not notify the stroke team. Okay, and stroke team consists of neurophysician, neuroradiologist, technician, MR, or in a CT scan or to the cath lab, and nursing staff. So they will be ready for their work. The second phase comes after the imaging, where we can decide about the recanalization treatment when the patient is coming with within the IV window period or within the intervention window period. The third phase start to prevent the complications because of the cardiac and respiratory problem, and the last phase, which range from days to weeks, where we want to prevent the complication which may happen in the acute phase of stroke and prevent the second stroke, so the secondary prophylaxis. So the goal of acute stroke treatment is to open up the blood vessels by chemical thrombolysis or by the intervention. And a few years ago we used to do with a time window. Now we are shifted to the tissue based treatment. I want to show this case like this. I want to explain on this. Like anywhere, if the artery is occluded leading to the two area, one is the center, that is infarcted tissue surrounded by the hypoperfuse area, and with the time its hypoperfuse area going to convert into the infarction. So this is called umbra, this is called penumbra. So conversion of the penumbra to umbra depend on so many factors, so it's not uniform in all patients. Okay, some patient may have even after 24 hours significant penumbra, and some patient maybe after 2-3 hours don't have any penumbra. So this conversion mainly depend on the arterial collaterals. If patient is having the good collaterals, that penumbra may be maintained for the longer period in comparison to patient who are not having the collaterals. So we have the three treatment. One, the patient if reaching in the IV window period, IV thrombolysis. If patient is having the large artery stroke, then we use this IV thrombolysis as a bridging therapy till we start the intervention. So intervention for the large artery stroke. And if patient is not candidate, then we have the to prevent the complications which may happen in the acute phase of the stroke, and those patients who underwent IV thrombolysis or thrombectomy. So again, they have to go through this medical management. Now, what is the window period? So for the IV thrombolysis, the window period is 4.5 hours. And for the thrombectomy, we can do up to 6 hours in almost all patients who present with the large and medium-sized stroke, medium vessel stroke, and having the aspect, that is the score we do on the CT scan. If patient comes after the 6 hours, we have to do this color imaging, that is called perfusion imaging, by which we calculate the size of infarct tissue as well as the penumbra. Like in the first case, this is the size of infarction and this is the size of hypoperfusion. Both are similar, means there is no penumbra. So this is not candidate even if this patient reaches in the 4 hours. The second patient having this much of an infarction, but there is a huge hypoperfuse area. That suggestive of there is a big penumbra, and this is the candidate even this patient reaching to the hospital after 20 hours. So this is the now to the coming to the thrombolysis part. If patient comes within 4.5 hours, we usually do the CT scan and RBS. CT scan not to see the infarction, just rule it out the hemorrhage actually, and RBS because the hypoglycemia totally may mimic with the acute stroke. So these two things is needed. But in this pandemic area, particularly COVID patient also reaching with a stroke, they can have the liver function derangement, they can have the low platelet count. So these two things more needed because you can't thrombolyze these patients if the platelet is low and liver function is deranged. So after this, if there is no contraindications, the contraindications are the same where you are doing the thrombolysis for the MI. The contraindication for the thrombolysis for brain is also the same. We have the two molecule. One is the RTPA and second is the tenecteplase. RTPA dose is 0.9 milligram per kg, just given 10% bolus followed by infusion of over a period of 1 hour. Tenecteplase you can give 0.2 milligram per kg by single dose. Most important thing when you are doing the thrombolysis or after the thrombolysis, you have to assess neurologically. First, in a first hour when you are doing infusion is going on every 15 minutes, and after this 30 minutes for next 6 hours, then hourly for 24 hours. If anything is developed, like patient develop the severe headache, suddenly raise in the blood pressure, nausea, vomiting, stop infusion, and again obtain the CT scan. Okay, patient may develop the hemorrhage, so you have to stop if any of these are developed during the thrombolysis. If you want to place a nasogastric tube or catheter, better to place before IV thrombolysis. Otherwise, wait for around 20 to 24 hours because that site may bleed. After the thrombolysis, you have to do the CT scan to decide about the anticoagulation and antiplatelet therapy, whatever is coming in the follow-up CT scan. The most important thing when you are doing the thrombolysis is monitoring the blood pressure. So if blood pressure before thrombolysis, if it is more than 180 and 110, you cannot thrombolyze this patient. You have to bring down the blood pressure less than 185 systolic and 110 diastolic before starting the IV thrombolysis. You can use the labetalol, you can use the nicardipine, you can use the hydralazine, you can use the enalapril. These are the drugs you can use to bring it down the blood pressure. And when after the thrombolysis or during the thrombolysis, you have to maintain the blood pressure around 180 and 105. And if it is needed, you can use the infusion of labetalol or nicardipine. And if the blood pressure is not controlled, you can go with the sodium nitroprusside. There is a clear-cut relationship between the blood pressure and acute ischemic stroke. Most of the patients who presented with acute ischemic stroke, they have the high blood pressure. Usually it's a reactionary hypertension, and it's settled down in most of the time in the next 3 to 4 days. If you're reducing the blood pressure in those patients, actually you're reducing the cerebral perfusion in a blocked artery territory, and you are increasing the size of infarction. So no need to hurry in reducing the blood pressure who presented with acute ischemic stroke. And if it's a significant high blood pressure, like more than 220 or 110 diastolic, there is always chances of hemorrhage and increasing the edema around the infarction tissue. So that is also related with the poor outcome. So you have to maintain that higher side like 150, 160, 170, but don't try to reduce more. There is a U-shaped curve relationship between case fatality and blood pressure. So a very low blood pressure as well as very high blood pressure, both related with the poor outcome. So best outcome observed between the 140 to 180 blood pressure in a ischemic stroke. So be careful when you are treating the hypertension in ischemic stroke. So this is about the IV thrombolysis. And IV thrombolysis we are having since 1996. The NIN style published in 1995. But unfortunate, because of so many barriers, only 8% of the ischemic stroke patient getting the IV TPA. The reason behind is one is the narrow window period. The second, the physician have the fear of hemorrhage. And the third thing is that successful reperfusion is only achieved in less than 50% of the cases with the large artery stroke. And you all know that large artery stroke related with the high mortality rate, like in the IC occlusion stroke present have the mortality rate around 3%, malignant AMC around 27%, and basilar artery around 90%. So the timely opening of these blood vessels is very, very important. You can reduce the morbidity as well as mortality. So to support this sentence, the three trials published in 2015, and all have shown clearly better result in comparison to just IV thrombolysis. In the group, the IV thrombolysis was used as a bridging therapy, and in these patients, only IV thrombolysis was given. And even the mortality was less in intervention group comparison to the IV thrombolysis. So what is the guideline says in scenario? If patient comes with 6 hours of acute stroke onset, if NHS score, the stroke severity score, if it is more than 6, and if aspect is more than 6 on CT scan, so that aspect is range from 1 to 10. 10 is perfectly normal CT scan. So that suggests there is infarction is not developed on the CT scan, and that is the candidate for the intervention. So you can do the intervention in large vessel occlusion. Large vessel occlusion means the basilar occlusion, IC occlusion, MC occlusion, or MCA bifurcation occlusion up to 6 hours. But you can do in the patient presenting with the IV thrombolysis, and they are having the contraindication. So you can directly shift patient to the cath lab, like this case. This 60-year-old female who was RSD case was on acetylene, presented to us with a 30-minute, but she was on the acetylene. Anticoagulation is not a contraindication, but INR should be less than 1.7 for thrombolysis. If INR is more than 1.7, you can't thrombolyze patient who is on oral anticoagulation. So in this case, it was 2.4, and you can see perfectly normal CT scan early sign of stroke, that is called dense MCA sign. So even the patient reached in the 20 minutes, we shifted the patient to the cath lab directly, and this is the MC occlusion and correlating with the CT sign. So we started opening. This is called a retriever stent. It's a non-detachable stent, and once it's deployed in the thrombus, it usually captures the thrombus. And after the two passes, the artery was opened up, and this is the clot we removed with the help of this retriever stent. And next, the CT scan, no dense MC sign, even the infarction is not developed. And this is the patient who came with the complete left side hemiplegia. She recovered just immediately after the thrombectomy. Another case who underwent CABZ 1 month ago, and he was on the dabigatran. This is a newer anticoagulation. Presented it to us with the NHS code 20, right side complete hemiplegia and aphasia. Reached to our hospital 110 minutes. Again, here is the two contraindication. One is the CABG done recently, and the second was that patient was on the dabigatran. Yeah, dabigatran we have the antidote, idrasuzumab. You just give the idrasuzumab 5 gram and you can thrombolize if you don't have the facility for the intervention. But we have. So I shifted this patient to the case. This is the pre-procedure patient. He is not following the command. There's a complete drift on the right upper limb. He is moving the left upper limb. Even there is no power in the right side, lower limb. Again, we shifted the patient. This is the MCA occlusion. Opened up in a 15 minutes. This is the clot we removed. And immediately, just after opening of the blood vessel, you can see the response.
चलो हाथ ऊपर करो हाथ ऊपर करो पूरा हाथ करो
We
ऊपर
started moving as soon as I opened up the left MCA.
ये हाथ ऊपर करो पूरा करो yes good
Okay, even after 5 hours, so he started speaking also. So patient who comes with the IV thrombolysis window period, but there is a contraindication with a large artery stroke, you can directly take this patient. Patient who comes in the intervention window period, like this lady who came around 5 hours of stroke onset, you can see there is an insular cortex involvement on MRI, but this damage is really smaller than what the patient is having neurodeficit. That is called radiological clinical mismatch. Probably this patient was having the large penumbra. So without wasting time, we took her to the for the intervention. You can see the MR angio. This is the MC, but there is a bifurcation block. And this is the first angiogram. You can see that one of the arteries opened up by its own, but there was a blockage in the superior division of MCA. And after opening, you can see that all the branches of superior division started flowing, and this was the clot. And this is the post-procedure CT scan. There is some hemorrhagic transformation, but these were not clinical relevant. And this is the first visit after the intervention. He recovered with a global aphasia and right side hemiplegia. Now, if patients comes after the 6 hour, so what to do in these patients? Why we are doing within the 6 hour? Because most of the patients they have the penumbra, so CT scan is sufficient for the intervention. But after 6 hour, we have to see how much penumbra is there. So this is the cerebral blood flow. It is this deficit related with the hypoperfusion. Cerebral blood volume picture shows infarct size. So if infarct size, the core size is less than 70 ml, if the mismatch ratio between the two is more than 1.8, if mismatch difference between the two is 15 ml, we can take this patient for the intervention. So this lady reached to our hospital after 10 hours of acute stroke onset. You can see the proximal ICU occlusion on the left side. We checked from the cross circulation. This is the right ICA. There was a cross circulation, but MCA was also blocked. So this lady was having the two block, one here at the proximal at the neck, and as well in the brain in MCA. So we started opening. We did the plastic first here, then I put a stent at the proximal ICA and open up the distal also. And you can see this patient came in my OPD on walking. She was having little weakness on the right upper limb, but having the motor aphasia, but she is totally independent. So this is the way we are doing the intervention in the present time. Now coming to the secondary stroke prevention, and it's depend on the etiology. The etiology divided into five segments. One is the stroke happening because of large artery atherosclerosis. Second is the cardioembolic origin. Third is the small vessel occlusion. Fourth is the stroke of other determined, that is called ESUS, sorry, other determined etiology. And the last one is the undetermined etiology, that is called ESUS. Means the patient is the two etiology on investigation. We don't know the which one is culprit. So we call is a undetermined etiology. If on investigation patient is negative for the etiology, we call it as a ESUS. If it is an incomplete evaluation, we call it as a ESUS. So we start with the first large artery atherosclerosis. Usually these patients presented with the stroke with the three mechanism. One is the artery to artery embolization. Second is a thrombotic occlusion at the site of plaque. And the third one is because of severe stenosis, patient developed the hemodynamic stroke because of the fluctuation in the blood pressure. In extracranial artery, these two are common, hemodynamic and artery to artery embolization. But in intracranial circulation, the mechanism is common. So the treatment depend on mechanism. Okay. So for extracranial artery, if artery stenosis non-significant, less than 50%, and there is nothing on plaque, you can give the antiplatelet for 3 months, then single antiplatelet. Sometime there is a thrombus over the plaque. Okay, so there is a chance that this thrombus may again migrate to the intracranial circulation. So if this situation is there, better to give anticoagulation for 3 to 4 weeks with aspirin than single antiplatelet. If stenosis is significant, there is a thrombus, then better to give anticoagulation to dissolve this thrombus and then do the CAE or stenting, like we did the stenting in this case. If hemodynamic significant stenosis like this, then directly stenting or CEA. Now coming to the intracranial large vessel atherosclerotic artery disease. After the Sempress trial, this was the trial where they have compared drugs with intervention, stenting, and it was negative trial for the intervention. So in the present era, you have to manage the all risk factor, good life habits, like you have to stop the smoking and regular morning walking, and with a double antiplatelet. Still patient is having the recurrence of stroke, then stenting is option. Like in this case, patient having the recurrent ICA minor stroke, so we did the stenting. This is the MCA, severe stenosis with the diabetes. He was having the repeated stroke. On the double antiplatelet, we put the stent. Again, patient was having the recurrent VBI, so we placed the stent. So first, you give the double antiplatelet for 3 months and manage the other risk factor like diabetes, hypertension, hypercholesteremia. Okay, so this is about the atherosclerotic artery disease. Now coming to the cardioembolic stroke, the most common cause of cardioembolic stroke is atrial fibrillation. Other than the atrial fibrillation, prosthetic valve and moderate to severe stenosis require lifelong anticoagulation. Cardioembolic stroke require for anticoagulation than antiplatelets. So we have the warfarin for last 40-50 years, but there's significant problem with the warfarin, like you have to manage the INR regularly, monitor regularly. There is the food and drug interaction. So in last 10 years, we have the newer multiple drugs, and all the newer drugs clearly show better in form of reducing stroke as well as systemic embolization, like dabigatran, apixaban, rivaroxaban, and endoxaban in comparison to warfarin. And there is no need to monitoring, and there is a hardly few drug interaction. Even in the form of complication in form of ICH as well as extracranial hemorrhage, all the drugs had a less complication in comparison to warfarin. So in the present time, NOAC is a drug of choice who are having the Chartwas score 2 or more than 2 with an atrial fibrillation, except patients who are having the mechanical valve or moderate to severe mitral stenosis, where you have to give the vitamin K antagonist. So the important thing in when to start. This is not for the oral anticoagulation. It is also for the heparin also after the stroke, because I have seen more hemorrhages because of the heparin than the IV thrombolysis. So patients who are having the TIA means that focal neurological deficit recover within 1 hour, and there is nothing on MRI. You can start on day one. If patient is having the mild stroke like this, you can start on day third to fifth. If moderate stroke, like less than 1/3 of MC, you can start on 7th day. If severe stroke, better to wait 2 to 3 weeks before starting the anticoagulation. This is about the cardioembolic stroke, brief. Now coming to the small vessel ischemic subcortical infarction. They usually present with a multiple stroke, smallest deficit. They can present with progressive dementia. They can present with a progressive vascular Parkinson. The best treatment is you have to reduce, you have to control the risk factor, diabetes, hypertension, amyloid, smoking, and these factors. And the choice of drugs in these cases is aspirin. There was a trial which done few years ago. They have compared the combination dual antiplatelet aspirin clopidogrel with the aspirin, and aspirin was superior in lacunar infarcts comparison to the dual antiplatelets. So for smaller lacunar infarcts, drug of choice is the aspirin. Now coming to the ESUS, yeah, you can say the cryptogenic stroke. This is the definition we have already discussed, and there is a criteria to diagnose ESUS. There should not be lacunar infarct, means there should not be lesion less than 2 centimeter. There should not be stenosis more than 50% on imaging. There should not be any major risk factor on echocardiography or on ECG and Holter, and there should not be other cause identified. Then you called ESUS. And if you diagnose ESUS, then you have to go with the extensive workup to find out the cause. If there is something like the mild to moderate stenosis on echocardiography, there is a regional wall abnormality, or suppose there is a ejection fraction low, better to evaluate for the long Holter, that you may get the atrial fibrillation in the long Holter. If you are thinking the patient is having the aortic atheroma or valvulopathy, then transesophageal echography is the better choice. One important thing I want to say that D-dimer is also very, very important test. If it is raised, it suggests you of two things, that either patient is having the hypercoagulable state, particularly in young. So in those patients, go for the hypercoagulable state workup. If patient is elderly and having the weight loss history, that probably patient is having the malignancy. So search for the malignancy. Now coming to the third part, the patient is having the fever. It's may related with the infection vasculitis. If patient is having the headache and repeatedly stroke, and MR-angio suggestive cerebral angiopathy, send for the autoimmune workup and go for the DSA and treat according to the etiology. For all is because it looks like embolic stroke, anticoagulation versus aspirin has been tried, like in the RESPECT with the dabigatran and NAVIGATE with the rivaroxaban. In both the trials, aspirin was superior to the NOAC in form of, because the major incidence of bleeding was similar in both the group, but clinical relevant hemorrhages were more in the anticoagulation group. So even in the SS, aspirin is the drug of choice at present time, except if you are find out the causes. The last is the stroke of determined causes, like patient is in the dissection, antiphospholipid syndrome, autoimmune disease, migraine-related stroke, vasculitis, pregnancy-associated stroke, marfanoid feature, cancer. So the treatment depends on the treatment of the etiology. This is about the secondary prophylaxis according to etiology of stroke. I want to say one thing. The patient who comes to you with a TIA or a minor stroke, we are also started giving the loading dose like the cardiologists are giving for the MI patient, clopidogrel 300 milligram and 150 to 325 aspirin. followed by maintenance dose of 75 to 81 milligram and clopidogrel 75 milligram for first 3 weeks. Why this is? Because most of the patients who presented with the TIA and minor stroke, other than the cardioembolic stroke, they have the recurrence in first 2 days and maximum chances in the first 2 to 3 weeks. So if you cover with these drugs, you're really reducing the chances of recurrence of the stroke. Conclusion, acute stroke should be treated as an emergency. Time is brain. You should be taken care of the time when you are treating the acute stroke. IV window period is 4.5 hours. Intervention, the window period is 24 hours, depend on how much viable tissue is available. Secondary prophylaxis should be decided according to etiology of the stroke. I think all the patients with the stroke should go with all these investigations like routine blood investigation, including lipid profile, ECG, echo, MRI. These sequences are required, like diffusion weighted for acute stroke, flare for old and new stroke, GI for the bleeding, and MRI and neck and brain vessels to rule out the large vessel atherosclerotic heart disease, and sometimes plus minus Holter for the longer period. Thank you so much.
Thank you, Dr. Mukesh. Very lucid and a very wonderful.
If one question can be asked to Dr. Mukesh,
Yeah.
if not a wish to ask, because both of you have similar field, Dr. Vishal could put some question.
Yes. We have Dr. Sylvie also here. If there are any questions, please go ahead. Dr. Sylvie, is there any question? You can unmute and.
For the wonderful job in terms of neurointervention he's doing. He has presented the case.
Thank you.
Thank you, sir.
Most welcome. Thank you for invitation. Thank you, everybody.
Thank you, sir. Thank you very much for the time giving. So nice of you. Thank you very much.